All ready, ma'am? Should we start?
Yes, sir.
Right. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 3G, which is soft tissue and bone pathology. We are streaming live from Basavatarakam, Indo American Cancer Hospital and Research Institute, Hyderabad, via Kolkata. We have a very interesting topic. The topic of the day is bony jitters. It's a slide seminar on interesting cases in bone pathology. And who better than the expert in bone pathology, the national and international expert, Dr.Suseela Kodandapani, who is an MD, PDCR, a fellowship in Cytopathology. She is a senior consultant pathologist and HOD pathology and clinical trials, and the member secretary institutional ethics committee at the famous Basavatarakam Indo-American Cancer Hospital and Research Center, Hyderabad. She has done her MD pathology from the famous Osmania University and has got the best outgoing graduate student award in the 1998. Did a postgraduate diploma in clinical research, fellowship in cytopathology from ISC, teaching faculty and thesis guide for DNB pathology. She's an NABH certified assessor of ethics committee accreditation, ICH and GCP guidelines trainer of NABH, member secretary of Institute Ethics Committee, Hyderabad. She is a very well-known guest speaker in various national and international forums with multiple national and international publications in peer-reviewed journals. Before I ask ma'am to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Suseela ma'am, please share your screen and let us start. Thank you so much. Yeah, we can see your screen, ma'am.
Yes, sir.
Good evening, sir. Good evening. Just share your PowerPoint, please. Yeah, that's fantastic. Yeah, no, please share your PowerPoint. It has gone again. Please share your PowerPoint. Sorry. Yeah. Please make it full screen.
Oh.
Again, it is gone. No. Just a moment. No, it's not coming. Yeah.
Coming.
No, it'll come. Don't worry. No, you just, yeah, that's right.
Yes.
Yeah. And just press that hide, please. Yeah.
Sir?
Yeah, please start, ma'am. Thank you. Okay.
Yeah, thank you, sir. Good evening, one and all. Myself, Dr. Suseela, from Basavatarakam Institute, Hyderabad. My sincere, heartfelt thanks to Dr. Nadeem, sir, and Neelam Pathology team for giving me an opportunity to present again in the same platform. And I also thank my young consultants, Dr. Lakshmi Manasa and Dr. Mohan Krishna, who helped me in the preparation of the presentation. And I help Dr. Kodandapani for his valuable inputs and of course his valuable critique and for his photos. Today I am going to share my experience in diagnosing the bone cases. That is why I called it as bony jitters. These cases are not exotic cases or very rare cases. They are the common cases which we come across day in, day out practice, and where we sometimes default and where sometimes we overdiagnose. And I just want to share my experience and where we went wrong and where we went correct. And sometimes we had fight with the clinicians also, who happens to be my husband. So again, I am insisting on multidisciplinary approach. So to get a definite diagnosis, we should have multidisciplinary approach, and coming together is a beginning, keeping together is a progress, working together is success. So we should always work together to arrive at a definite diagnosis. So my first case is 55 years male, having complaints of severe continuous incapacitating leg pain not getting subsided with analgesics for the past 3 months. it was progressively getting aggravated, difficult to do even day-to-day routine activities. He is a known case of chronic myeloid leukemia on treatment with tyrosine kinase inhibitors. He could not tolerate imatinib, which is being prescribed for 9 months, and now they stopped the treatment. And this is the radiograph showing the heterogeneous osteolytic. I think all of you can see. Sir, is it clear, sir? X-ray? Hello? Sir, am I audible? Hello? Hello? Hello?
Yes, ma'am. You are absolutely clear.
Okay,
Absolutely.
sir. So,
please go
this
ahead.
is the X-ray revealing the osteolytic and sclerotic lesion in the left femoral neck and the proximal condyle, intercondylar region extending to the lower trochanter also. So, it is involving the condyles, everything. So, the radiologists, they opined us, it could be leukemic infiltrates or it could be infective etiology. So, first, this is the lesion. And first, we did FNAC. And FNAC, we just saw sheets of foamy macrophages and inflammatory cells. We could not come to a definite diagnosis, but we told it is negative for malignancy. And CBP, RFT, LFT, everything was within normal limits. And the patient showed complete hematological remission, that is CML in chronic phase, but molecular studies reveal persistence of disease. That is the BCR-ABL. When we did RT-PCR, the BCR-ABL major fusion transcript is 38%. Usually it should be less than 1%. So the oncologist felt true cut biopsy should be done. Even true cut biopsy was not helpful, and then they went ahead. This is the true cut biopsy. It was showing only the fibrous tissue with scattered foamy macrophages and fibroblasts. Again, we insisted that there is no evidence of malignancy. But as usual, the clinicians, they didn't agree with our diagnosis. So since the patient is having severe debilitating pain and the radiology was very suspicious, patient was insisting on undergoing surgery. So he has undergone surgery and resection of left proximal femur with the tumor endoprosthesis done, and he was started on oral nilotinib, which is the next generation tyrosine kinase inhibitor, since he is not tolerating imatinib. So histopathology, this is the post-operative radiograph showing the prosthesis. So this is the specimen which we got, that is the head of the femur, and a cut section showing fibrosed areas and little normal marrow, and we did gridding, and microscopy showed diffuse coagulative necrosis of marrow cells and empty osteocytic lacunae in bone trabeculae, and other field dense fibrosis and hyalinization. So there are inflammatory cell infiltration and infiltration of foamy cells, lymphocytes, and there is fat necrosis also. So bone marrow elements are seen here and there are foamy histiocytes which we got in cytology. So dense hyalinization and recovering bone marrow elements and little normal bone is also seen in the sections. We have done the gridding, so almost whole sections we have taken. So IHC we did, MPO has come negative and CD34 also negative. Then we did pancytokeratin, that is also negative. So it is not a metastasis, it is not leukemic infiltrates. So what it is? Then we did vimentin, the dense hyalinization and fibrosis, it took up the stain, and this is the last stain which helped us, it is CD68. So it stained all the foamy histiocytes which we saw in the section. So what could be the diagnosis? What to give? We were just breaking our head, and ultimately we just gave it as no evidence of malignancy in the section studied. In view of extensive hyalinization, dense fibrosis, foamy histiocyte infiltration, bone necrosis, and mononuclear inflammatory infiltrates, we favored reactive and inflammatory changes, probably chemotherapy related, associated with imatinib therapy. So this was the final diagnosis which we gave after studying the histopathologic section. And regenerating normal bone marrow elements are also seen. So the patient is getting regenerating marrow. So on follow-up, that is on 19/2/20, the operation was happened in 1918. So the patient is tolerating oral nilotinib and absolutely no pain and walking comfortably and started his routine life, and he started attending his office also. CBP, biochemical parameters, everything was within normal limits, and the patient has attained complete hematological remission and also major molecular response. That is the real-time PCR, BCR, ABL major fusion transcript is 0.05%. So that is how the story ended. The patient is happy and the clinicians are also happy, though they are not happy that it is not leukemic infiltrates. So chronic myeloid leukemia, as we all know, it is the BCR ABL translocation is there. So the CML cells express the tyrosine kinase activity, which is blocked by the drug imatinib, and it is the first signal transduction inhibitor and which has the potential protein tyrosine kinase inhibitor. It is used clinically long time since, that is 1988 if I am right. And the side effects of imatinib is usually short term and long term. So short term is fatigue, nausea, abdominal pain and diarrhea. And in this patient, the patient has developed severe hepatic toxicity and little kidney failure also. But nobody noticed about the fibrosis, all the side effects of the imatinib in the bone marrow. And nilotinib is a selective BCR ABL tyrosine kinase inhibitor and is 30 times more potent than imatinib with less side effects. And this patient is tolerating nilotinib. He could not tolerate the other drug imatinib. So the rare things will happen in the day-to-day routine also. So we should be aware of this kind of changes when the patient is on imatinib. So we should not get upset or this thing when we don't see any CML infiltrates in the bone. We should search everywhere. If we are confident, we have to inform the clinician about the same and then look for the other reasons for the severe pain, because the interleukins and all the acute reactive substances that caused the pain, and the patient is absolutely pain free now and he is very happy taking care of himself. The case number 2 is 20 years male having complaints of pain and swelling in the left knee for the past 1 month. The radiograph, CT scan, bone scan, everything was done and all basic hematological and biochemistry investigations are within normal limits. Twice the patient has undergone true cut biopsy and both the times it was hemorrhagic and it was inconclusive. So the clinician sorted out for open biopsy, that is he did curettings and which was sent for histopathological examination. So this is the radiograph showing the lytic lesion, osteolytic expansile osteolytic lesion in the metadiaphysis region of the lateral epicondyle of left femur. So according to the radiograph, it is Cori GCT, Cori ABC. In the previous lecture also I told about the radiographic features. So here it is a well-defined swelling having a thick border. So it is Cori GCT because it is having fluid inside, it could be ABC also. So CT scan show again the same liquid filled cavity, ill-defined expansive lytic lesion, Cori ABC, Cori GCT. So the bone scan revealed increased vascularity, pooling and uptake of tracer in distal femur, again the same Cori ABC, Cori GCT, and no other focal hotspots are noted in the skeleton. In lab FNAC smears, I have already told they were hemorrhagic, and true cut biopsy showed normal bony trabeculae, so that was also not conclusive. So open biopsy. These are the curettings we received. Now I think you got the diagnosis. This is the lower magnification showing the normal bone with dilated vascular channels. Higher magnification showing fragments of fibrocollagenous tissue with inflammatory cell infiltrate and congested vascular, capillaries and irregular reactive osteoid with mineralization. Okay, so normal bony trabeculae are also seen. Congested vascular vessels are there with well-defined endothelial lining. Higher magnification showing the endothelial lining. So with this, we came to the diagnosis of hemangioma bone with reactive changes, and there is no evidence of malignancy. So always whenever we see, this is the post-treatment radiograph showing the curettage followed by reinforcement of the bone by intralesional elastic nailing and cementing. And the hemangioma of bone is a benign vascular tumor of bone, usually occurs between 20 and 50 years. There is no definite gender preference, and it is common in vertebra but uncommon in long bones. In our case, it is in the long bones. And whenever there is a fluid filled cavity, we should think of hemangioma also. We should be considered as a radiological DD for bone cyst and aneurysmal bone cyst. And pathologists should keep it in mind whenever the sample is highly hemorrhagic. Repeated sampling also becoming inconclusive means we should think of hemangioma of bone. So case number 3. It is a 9-year-old male presented with swelling in the left thigh for more than 1 year and pain for the past 7 months. No history of trauma or any other swelling found in other parts of the body. No history of weight loss or fever or anorexia. On local examination, there was tender diffuse swelling which was measuring 10 into 5 centimeter. There was no sinus or any discharge noted. X-ray, CT, MRI, everything was done. And I will be showing it. And true cut biopsy was done twice. Diagnosis was inconclusive as the samples were inadequate. In the series of cases, most of the cases, the true cut biopsy or FNAC, they were inconclusive and we could not get enough material. Then they resorted the procedure open biopsy or again true cut biopsy. Those are the difficulties we faced in this series of cases. So diagnosis was inconclusive as the samples were inadequate. After the open biopsy, diagnosis of giant cell lesion, that is Cori GCT with ABC like areas was made. So excision biopsy was done and sent for histopathology. So this is the X-ray showing the lesion, eccentrically located lesion, expansolytic in the medullary cavity involving the diaphysis. Okay, with the solid and cystic areas, I think we can make out fluid levels also in this. And this is the angiogram showing the increased vascularity. So loss of cortex in the posterior aspect and an exophytic soft tissue mass in the posterior compartment. That is also seen in the picture clearly. So the DD is favoring the telangiectatic osteosarcoma over the giant cell tumor of lower end of left femur. Then this is the excision of the tumor because twice true cut biopsy and FNAC was showing only scattered giant cells and twice true cut biopsy done and again and again we called it as giant cell lesion. We could not tell more than that. So ultimately the patient has undergone the limb salvage procedure and this is the cut surface showing the blood filled cavities. So cavernous spaces filled with blood surrounded by osteoclast giant cells. Here the matrix calcification is there, that is the blue bone formation is seen, and ovoid spindle cells which are bland in nature admixed with osteoclast giant cells, but there is no vascular endothelial lining in the blood pools, and some areas are showing the nodular fasciitis like appearance. Any guess? Okay, so it is a case of solid variant of aneurysmal bone cyst. The ABC is a pseudocyst of bone filled with blood separated by fibrous septa and can be primary or secondary along with the other lesions such as fibrous dysplasia or malignant tumors. Solid variant of ABC is an uncommon entity accounting for less than 10% of the ABCs. First described in the year 1983 by Senerkin NG. So solid variant of ABC involves the diaphysis that we always should remember, has solid areas with few of cavernous spaces filled with blood, surrounded with fibroblasts, sclerosis, scattered osteoclast giant cells, and areas of heterotopic calcification, that is the blue bone formation, and immature osteoid with or without osteoblast rimming, but no atypia. This thing we should remember because there will be immature osteoid, so the texture will not be uniform, but there will be no atypia. There may be osteoblastic rimming also, so we should not commit the mistake of osteosarcoma whenever we see such areas. Because of the aggressive nature, more often it breaks the cortex and involves the soft tissues, as in our case, giving a pseudo appearance of malignancy. And in view of the varied histology and radiology findings, it is easily confused with spindle cell neoplasms like giant cell rich or telangiectatic osteosarcoma or giant cell tumor, malignant giant cell tumor also. And the majority of primary ABCs have typical cytogenetic rearrangements of the USB6 gene, which are not seen in secondary ABCs and in other malignant bone tumor mimics. In our case also, we sent the sample outside for USB6 gene and we got the positivity. So it confirms the diagnosis of solid variant of ABC. So this is the post-op radiograph showing the excision of shaft of tibia with microvascular free fibula reconstruction. So the other side fibula is reconstructed here. So case number 4 is 24 years male having complaints of pain in knee for the past 2 months, which was gradually increasing and diffuse and painful swelling. There is no history of fever or injury. ESR is not raised. All biochemical parameters are within normal limits. After radiological opinion, true cut biopsy was done. So radiology wise, it is the distal femur, left knee, lytic and sclerotic swelling, left medial femoral condyle with extension into medulla. So Ewing sarcoma, this is the radiologist's opinion. So with this diagnosis, they went into true cut biopsy. So this is the true cut specimen showing the sheets of small blue round cells with scanty cytoplasm which is infiltrating the bone. Higher magnification showing the monotonous population of cells, blue cells. So we went ahead with the IHC, small blue round cells arranged in sheets, no organoid pattern, no definite pattern is there, and CD99 came out to be negative, FLI1 is also negative, SADB2 is also negative, NKX 2.2 is also negative. So then we did CD3 and then CD20, which has come diffusely positive. So we had the DD of Ewing's and small cell osteosarcoma only. We never thought it will turn out to be CD20 positive. That is, it is a primary bone lymphoma. Why we called it as primary bone lymphoma means because there is no previous or concurrent extraosseous disease of lymphoma except regional nodes. Regional nodes not yet confirmed. We got the case recently and the nodes are mildly enlarged. And so the diagnosis of diffuse large B-cell lymphoma, that is DLBCL, which is the common type seen in bones, and it has 80% favorable prognosis. Other IHC markers are done and the patient is MUM1 negative, that is GCT, germinal center type, non-germinal center type. So germinal center type will have CD10 positive or negative, BCL6 will be invariably positive and MUM1 will be negative. In non-GCP, CD10 will be negative, BCL6 will be negative and MUM1 will be positive. Otherwise CD10 will be negative, BCL6 will be positive and MUM1 will be positive, which is having a bad prognosis. In our case, it is GCP type, which is MUM1 negative. So let us take a break. So coming to the next case, that is case 5, 16 years male having the complaints of swelling thigh for the past 8 months and gradually increasing pain, and there is no history of fall. There is a history of fall, and X-ray showed a lytic lesion with cortical break and calcification and pathological fracture. True cut biopsy was done after radiology, and this is the radiology picture showing a very bad lesion. We can make out the fracture also, and the growth is seen outside the bone also, involving the soft tissues. Am I audible, sir? Hello?
Absolutely audible. Please go ahead. Yeah.
Yes, sir.
And we can see your X-ray also clearly. No issues.
Okay, sir. So this is the true cut biopsy. I just magnified the pic. It was only one strip of biopsy, which is showing islands of cartilage with small round cells admixed with blood vessels. So we don't know what it is. So we had all 3 possibilities. One is Ewing sarcoma because of the small round cells, and a part of cartilage is also there. So we had a doubt. 2 things are there. So is it mesenchymal chondrosarcoma, or according to the X-ray, we had a doubt of small cell osteosarcoma also. So we went ahead with the IHC. CD99 was positive, FLI1 is also positive, S100 is positive in the cartilaginous area, and NKX 2.2, SADB2 and desmin are negative. So SADB2 rules out the osteosarcoma, desmin rules out any DSRTC, and NKX 2.2 negative means whether it is Ewing's or not, we have a doubt because FLI1 has come positive. Then we went ahead with the EWSR1 gene rearrangement, which showed no rearrangement is seen. So it is showing normal signal pattern. So it is negative for any rearrangement. So we ruled out the possibility of Ewing sarcoma. Patient has went ahead with the limb salvage procedure. It is like this big mass has been removed, and this is the histopathological picture showing the biphasic round cells around the blood vessels admixed with cartilaginous areas, and another field showing the lobules of cartilage and the small round cells and the hemangiopericytoma appearance of the vessels. And this is a higher magnification showing the monotonous cell biphasic pattern, and this is the other field. So with this we came to the diagnosis of mesenchymal chondrosarcoma, which is a high grade aggressive neoplasm and has biphasic morphology composed of round cells arranged around the blood vessels admixed with cartilaginous areas, and IHC wise CD99 SOX9 will be positive in round cells, S100 will be positive in cartilage, and Fly1 plus or minus, and NKX 2.2 will be negative, and INI1 is retained. We didn't do INI. INI1 will be retained. And another interesting thing about the mesenchymal chondrosarcoma is routine conventional chondrosarcoma will be IDH1 and 2 positive, but mesenchymal variety will be IDH1 and 2 absent will be, it is negative for IDH1 and 2, and it harbors a recurrent HEY1 NCOA2 rearrangement also. We don't have any facilities to find out this rearrangement. So post-operative X-ray showing the endo processes in situ. Patient is walking about well now. So case number 6 is a 12-year-old girl presented with pain and swelling in right thigh for the past 1 month. There is no history of any injury or fall or fever, and CBP and CUE everything is within normal limits, and the serum parathormone, blood urea, creatinine everything is within normal limits, and alkaline phosphatase is increased. Clinical diagnosis was osteosarcoma stage 4 in correlation with the hemangiology, and patient has undergone true cut biopsy twice followed by open biopsy, because both the times the biopsy was I will show you the pictures. And this is the X-ray showing the pathological fracture here and permeative osteolytic lesion in the distal half of right femur, that is the thing, and here we can make out in MRI clearly big lesion in the distal half with periosteal reaction, and intramedullary lesion involving the whole distal half of the femur. And coming to the bone scan revealed the lung deposits also. So this is the first biopsy which we received, and it showed only the reactive fibroblast, that is the reparative tissue composed of spindle cells and scattered giant cells, osteoclast giant cells. We could not give any definite diagnosis. There are some atypical large cells, but we don't know whether they are reparative cells or they are neoplastic cells. We went ahead with IHC. So S100 was negative, SADB2 was negative, P63 was negative, all the markers are negative, and Ka67 is less than 4%. So we could not come to any definite conclusive opinion. So we asked for a repeat biopsy. So repeat biopsy was done. That here the section showed atypical spindle cells. Now they are more atypical, and there are giant cells, and there are some ABC like areas. So this again complicated our diagnosis, and we are little jittery to face the clinicians, because the girl is a small girl having lots and lots of pain. So they are forcing us to give a definite diagnosis. So we went ahead with the IHC. S100 again it has come negative, and SADB2 has come positive. Okay, block positive it has come, and P63 is also positive. So P63 is also positive, and SADB2 also positive. So we just got confused, and this E section is showing Ka67, which is more than 60%. So it is a malignant lesion, that is for sure, and since SADB2 has come positive, it must be osteosarcoma. We just thought maybe associated ABC areas, they have gone into the ABC areas. So again we took our strength and asked for repeat biopsy to the clinician. So they did the open biopsy. Here we got the sheets of atypical mononuclear cells which are showing marked pleomorphism with multinucleated osteoclast giant cells which are more in number, and the mononuclear cells show enlarged hyperchromatic nucleus, irregular nuclear membrane and scanty cytoplasm, and there are dilated vessels also. So at last we found the osteoid in between the giant cells. So with this we came to the diagnosis of giant cell rich osteosarcoma of the right thigh. So giant cell rich osteosarcoma is a rare variant of conventional osteosarcoma. Bathurst and Senkin first reported in 1986 for the first time, and 3% of conventional osteosarcoma constitutes giant cell rich osteosarcoma. A male is to female ratio is 1:3. In our case, it is a female baby, and the frequent location is diaphysis of the femur, and it is very difficult to distinguish from GCT by radiography or MRI if it is confined to the bone, and if radiologically evident lesion is present, we should not hesitate to ask for repeat samples like we did in our case, though we got lot of scolding from the clinicians for bothering a small kid. And it is important to have high index of suspicion, especially if skeletal maturity is not there. So in our case also, the baby is very small baby where the skeletal maturity not happened. So we should search for osteoid matrix in the specimen. So if needed, we have to submit the whole specimen in toto. This is one view of our hospital. So case number 7 is 8-year-old girl presented with gradually progressive painless swelling in the left forearm. MRI showed a 5.6 centimeter mass lesion in the posterolateral aspect of forearm infiltrating the muscles. The true cut biopsy done, here also it was done twice. First time it was totally hemorrhagic and normal muscle fibers came, and second time we got enough material and we did IHC and confirmed the diagnosis of Ewing sarcoma. So 6 cycles of neoadjuvant chemotherapy including vincristine cyclophosphamide given to the patient, and the excision biopsy done in view of MRI findings, because I will show you the findings. So this is the first true cut biopsy, in which we confirmed the Ewing sarcoma, showing the monotonous population of round cells, and CD99 nicely positive, and NKX 2.2 nuclear positivity is seen nicely, and desmin is negative. So sheets of round cells showing all the positivity for CD99 and NKX2. So we gave the diagnosis of Ewing sarcoma, and this is extraskeletal Ewing sarcoma because the bone is free from the tumor. It is occupying the whole muscle and soft tissues. After the chemotherapy, patient has undergone MRI because there was persistence of the lesion, and here we can make out a big lesion staying stable comparing with the pre-chemo MRI. So post-chemotherapy MRI showed the well-defined lobular altered signal intensity lesion measuring 6.2 centimeter, and it is suggesting a residual tumor. So since the radiologist insisted that it is a residual tumor, and clinician didn't do repeat biopsy in this, they have directly went on to the wide excision of tumor with clear margins. So microscopically, diffuse proliferation of fibroblasts interspersed with numerous congested vessels, and there are aggregates of pigment-laden macrophages replacing the tumor, and there is absolutely no necrosis, and there was no residual tumor cells seen in all the sections. So we went ahead with the IHC, CD68, because we learned lesson from the CML case. So we went ahead with the CD68, it was nicely positive. Then calponin, again staining the fibroblasts, NKX 2.2 is negative and S100 negative. Then Ka67 is hardly 1 to 2%. So with this, we came to the diagnosis of post-chemotherapy effects in a case of Ewing sarcoma. Actually, the patient is totally devoid of tumor. Tumor has totally got disappeared after the chemotherapy. So Ewing sarcoma differs from osteosarcoma because it does not produce any extracellular matrix. So that makes difficult for the histopathology people to assess the chemotherapy response in these tumors. Because if in osteogenic sarcoma we can make out the osteoid matrix, with that we can calculate. But here, if there is no necrosis, it will be very difficult to assess the chemotherapy response. Usually we get the necrosis, but in our case the crucial thing is there is absolutely no necrosis. Rarely the tumor can be replaced by a proliferating fibrous tissue without necrosis, as in our case, which may not change the enhancement in MRI, resulting the misinterpretation as poor response. Even in our case also, the MRI could not make out the because there is no necrosis, so it was looking a solid tumor as in the pre-chemotherapy picture. So they called it as poor response post-chemotherapy. In such cases, extensive sampling with thorough morphological examination should be done, and assistance with the IHC will help us in accurately diagnosing these lesions. So coming to the case number 8, it is a 22 years male having complaints of swelling in knee, pain and warmth, and no history of injury. The ESR is slightly elevated, that is 20 millimeter per hour, and biochemistry serum alkaline phosphatase is increased. True-cut biopsy done, and diagnosis of conventional osteosarcoma made. 4 cycles of wide regimen is given, that is vincristine, ifosfamide and doxorubicin and etoposide is given, and limb salvage procedure done after the 4 cycles. This is the X-ray post-chemo showing the lytic and sclerotic lesion. So they called it as core-residual osteosarcoma. So this is the bone which we received after the limb salvage procedure, and the gridding is done for it. So the whole bone is submitted, and ABCD like that we give the sections. So these are the different views of the histosections, and we see bony spicules like fungal elements. This thing we should remember. When we saw it for the first time, we thought, what is this fungal infection in a post-chemo osteosarcoma bone? But they are not fungal elements. They are the bony spicules which are partly destroyed and partly present. And residual tumor cells are seen, and osteoid matrix, which is immature osteoid, it is seen in between the tumor cells. These are other fields. Areas of osteoid matrix is seen, and little calcification is also seen, and here the trabeculae of the medullary bone is also seen, and residual tumor we can make out in many sections. So the status is post-chemo and residual tumor is present. Now we have to take the grading also. This is the post-operative radiograph showing the processes in situ, and the grading of chemotherapy effects by Pixie et al. It has been nicely defined, and the same cutoffs for osteosarcoma as well as for Ewing sarcoma. I have mentioned that in the previous lecture also. So whenever there is 90% of tumor necrosis, we should call it as good response. So grade 1 is less than 50% necrosis, and grade 2 is 50 to 90% necrosis, grade 3 is 91 to 99% necrosis, grade 4 is 100% necrosis. In the previous case of Ewing sarcoma, where we could not see any necrosis, we presume that it is 100% necrosis, and we called it as grade 4. But in this case, it is having 50% of necrosis, so it came under the grade 2 lesion. So coming to the case 9, 20 years male, painful swelling right hip for the past 8 months, and the true-cut biopsy done and confirmed the diagnosis of GCT. So patient was started on denosumab, 4 doses have been given, and then after the reduction of the size of the tumor, excision of the tumor done. This is the radiograph. It is a huge swelling and a large expansive lytic lesion with the internal septation at the proximal end of right femur. So this is the GCT picture. So true-cut biopsy confirmed the GCT, spatial arrangement of the stromal cells and the osteoclast giant cells, and the excision biopsy specimen post denosumab, and a substantial new bone formation is seen, and bland stromal cells are seen here and there, and we can make out in the low power also there is no osteoclast giant cells. Even in this picture also there are cystic spaces, foamy macrophages are there, and inflammatory infiltrates are mild, and hemangiopericytoma appearance is also there, and dense hyalinization, and hemosiderin-laden macrophages are also there, but markedly there is an absence of osteoclast giant cells. So final report is therapy effects in GCT post-denosumab case. So right proximal femur section specimen showed only the therapy effects. There is no neoplastic cells. But in GCT, the stromal cells are the neoplastic cells, not the osteoclast giant cells. So the denosumab is not chemotherapy drug. That thing we should remember. So it doesn't destroy the neoplastic cells. It will just make the osteoclast giant cell. They will block the effect of osteoclast giant cells. So this is the post-operative pic, and denosumab is a rankle inhibitor, so it will arrest the osteoclastic activity. So osteoclast giant cells will be removed, so osteoblastic activity will be promoted. So that will reduce the tumor associated bone lysis. So new bone formation will be there, and osteoclast giant cell formation will be reduced. So that is the function of denosumab. So we should always remember it is a monoclonal antibody, not a chemotherapy drug. With that, we come to the end of the session. So the lessons we all learn from this is we should never hesitate to ask for clinical history. If there is no clinical history, we should not report, and we should never hesitate to consult the radiologist. If we can interpret the X-ray or CT scan, we can do by ourselves, but it is always better to interact with them. And we should never hesitate to discuss if there is a discordance, and in case if we did some mistake, we should be open and frank to accept our mistakes. That will solve a lot of problems, and we should never hesitate to do panel of ISC. We should not limit ourselves. I know very well it is financial restriction is there in all the setup, but we should convince the clinicians to get the panel of ISC done, and because with one ISC it will be difficult. If we would have done only fly one in that patient, then we would have gone wrongly. We could have diagnosed as Ewing sarcoma instead of this Mesenchymal chondrosarcoma diagnosis. So we should never hesitate to do panel of ISC, and in case if needed, like fish and all that, ancillary tests also we should do. And we should never hesitate to get consensus. Sometimes we have some focus in mind, and whatever we did, we feel what we are doing is right. So if we have little doubt also, we should consult our colleagues, whether they are junior or senior, it doesn't matter, because each one has their own views. Without biasing them, we should give the slides and ask them to opine on that. And we should never hesitate to keep ourselves updated, because the pathology is changing day by day, so we should always get ourselves updated. So together we can always do miracles. So this is my team, which is my backbone. So thank you very much.
Thank you so much. Wonderful cases, remarkable.
Thank you,
and
sir.
that last slide is the most important slide. Yes, the persistence, insistence to the surgeon, to the orthopedician, that no, we have not got enough. Let them scream and shout at us. So what? Final diagnosis matters.
Yes.
That is the most important take-home message.
Yeah.
When irrespective of where you stand and who you are, it's best to talk to them and tell them that we still cannot come to a point. Please help us, give us more tissues.
Yes.
And many a times when they take out the tissues, they're all necrotic, they're all blood clot, and there's small
sir, many
fragments
times
of tissues.
they give normal tissue also, sir. And they used to tell that we have given 2 centimeter tissue and still you are telling no tissue. Whatever tissue they have submitted may be normal tissue. So absolutely, we should sometimes fight with them only.
Yes. That fighting is very much healthy fighting, it's very important.
Yes, sir.
Yes, because that is what all the juniors have to be taught.
Yes, sir.
That if you insist, you will get material and you will get the history, the radiology, and without all this, it is very difficult to come to a conclusion. And some of the cases, that primary lymphoma of the bone was excellent.
Yes, sir.
And that mesenchymal chondrosarcoma, it's a very difficult diagnosis.
Yes,
it's
sir.
good that it struck your head, otherwise it could have gone anywhere. It's a wonderful diagnosis. I think you must have
So
published
with
it. Did
that
you publish
case,
that?
literally, I had to fight with the clinician, and my luck, the clinician happens to be my husband, so the fight
Yeah.
was going on at home also.
Yes, that's important. I can understand. I can understand the level of fight. But
Yes,
then that is very important. You have to keep pushing because these diagnoses are not easy to come, and when they come, they are very helpful in the
Yes.
final treatment of the patient.
Yes, sir.
And I think that last slide of yours is to be preserved. It is very, very important.
Yes, sir.
And
Thank
it's
you
a
very much.
wonderful presentation, so nice cases. And
Yes, sir.
especially one more thing which I want everybody to listen very carefully is that picture which actually looks like aspergillus, but
Yes,
actually
sir.
it is not aspergillus.
Yes, sir.
It can be a real difficult situation for everybody.
Yes,
So
sir.
that is something which I think it's something which if one learns from experience.
Yes, sir.
And it is nice that you have come and shared your experience with us and with all of us here, so that we can learn and we can learn from others and be better in our treatment and diagnosis. Thank you.
Yeah, thank you
so
very much,
much,
sir.
Dr. Suseela. Thank you so much for taking so much of trouble. You are
Yes.
such a busy pathologist there, I know.
No,
You've
no,
got
sir.
such a
Not at all.
busy
It is a
hospital
pleasure, sir.
team.
It is a pleasure to share our experience.
Yes,
And really, I am thankful to you to share, to make me share my experiences. And I am
The pleasure is
really
all mine,
privileged.
ma'am. It's an honor that you are on this platform. It's an honor for the students, the consultants, the residents who are listening and seeing this again and again, to have you teaching them.
Yes, sir. Thank you.
It's a big honor for us. Thank you so much, ma'am, for taking out time.
Yes.
But let me tell you one thing, I'm not letting you go. After 2 months, I'm again going to come back to you with some
Yes,
other
sir.
topic.
I'm
You are a
happy
wonderful teacher.
Happy to be with you. Yes,
Yes,
sir. No
please,
problem,
please,
sir.
please take out time for the students. Thank you so
Sure,
much.
sir. Thank
God
you, sir.
bless
Thank
you, ma'am. Take care.
Thank you,
Good
sir.
night. Take care.
Yes,
Bye-bye.
sir. Good
Thank
night,
you
sir.
so
Good
much.
night. Bye, sir.
Good night. Thank you. Bye.